time for people to join. Without further ado, I'm going to hand over to Rabie, who's, as I mentioned, part of the maxillofacial team that's currently rotating with us. It's an absolute pleasure to host you, and we really look forward to the meeting. So without further ado, I'm going to hand over to you.
Good morning, guys. As Louisa said, I'm Evan. Thank you very much for this opportunity to present on Osteoradionecrosis today. I'm from the University of Pretoria. This is the old arts building on main campus, right across from the Ola, which is it's a favorite romantic destination for students at the University of Pretoria. I always feel if I'm in Cape Town, I should apologize for my Afrikaner accent, so hopefully most can understand me fairly well. This is our beautiful city in the month of October. The street on the left is in Lawley Street in Waterkloof, and the right-hand picture is Parliament Road leading up to the Union buildings. So these purple flowers are very beautiful and romantic, but it's also a signal that the students have to start studying for end-of-year exams. So it has quite a mixed, it elicits quite a mixed emotions. So I'm gonna keep this lecture fairly simple. So the outline is I'll quickly just discuss the history and definition of ORN. So then I'll look at the etiology. Obviously, we know it's about patients that had radiotherapy, but there's a number of risk factors that needs to be kind of just elucidated. I'm going to look at the pathophysiology, particularly with regards to two theories that is, I would say, shaped our treatment philosophies in the past 30 years. Some of the clinical features and just why it is so important to kind of, from a history elicit that the patient had radiotherapy, etc., because there's a number of conditions that present very similar to osteoradionecrosis. Some of the radiologic features, classifications, and then I'll spend most of the time at the management, which will be divided into two groups, both those people that are at risk of osteoradionecrosis, as well as those patients that's got established osteoradionecrosis. So let's, so the history was first described by Rigaud in 1922. There's a number of alternative nomenclature, including radiation osteitis by Ewing and septic osteoradionecrosis by Gutenberg in 1974. At this time, Gutenberg had culture results that showed that there was a bacterial infection of the sequestri sent for culture and sensitivity testing. But Marx in 1983 showed that there's a material difference between the culture specimens from conventional suppurative chronic osteomyelitis and those of patients with osteoradionecrosis. He found that the cultures, the bacterial cultured from the osteoradionecrosis sequestri was commensal bacteria, and that was hence only a secondary phenomenon. And he's the one that pioneered the idea of the 3H etiology of osteoradionecrosis. So just as a definition, the big thing with a definition, there's currently no standardized case definition. So up until the early 2000s, the main case definition that was used in clinical trials and studies were that of Marx from 1983, which defined osteoradionecrosis as a 1 centimeter area of exposed bone in an area of radiation that is not healing for a period of 6 months. But the more universally accepted case definition at this time is that of non-healing exposed bone for a period of more than 3 months with no evidence of persistent or recurrent tumor, implying that you have to do a histology of the site, or at least of the resection specimen, with a patient of history of radiation. For completeness sake, I included a definition of medicine-related osteonecrosis. It's maybe not a condition that our ENT colleagues often are faced with, but in dental practice, medicine-related osteonecrosis is probably more prominent than osteoradionecrosis, just due to the fact that a lot of GPs these days inject patients with IV alendronate, and patients then present for dental extractions with non-healing wounds. So the history of, or the case definition by the American Association of Oral Maxillofacial Surgery is that of history of bisphosphonate use of exposed bone for more than 8 weeks and a negative history for head and neck radiotherapy. So just to kind of use that as a diagnostic criteria. Then looking at the etiology, so obviously we know that the etiology is directly related to either a new adjuvant together with adjuvant radiotherapy, or either as a primary modality of care or as an adjuvant treatment of the primary surgery. So the risk factors is more than 60 gray of radiation therapy, and it seems to be that brachytherapy has got higher incidence of osteoradionecrosis compared to external beam radiotherapy. Concurrent chemoradiotherapy increases a patient's risk, and then anatomical subsites. Obviously, I'll show a picture of IMRT and how beams are designed, and you know, posterior tumors tend to have higher areas that cannot be protected with regards to how the beam is designed. So posterior tumors like nasopharynx tend to have a higher ORN rates compared to that of oropharynx. A recent systematic review showed that nasopharyngeal squamous cell carcinoma patients that were irradiated has got a risk of about 12 to 15% of osteoradionecrosis compared to tongue tumors with looking at 1 to 2%. And then there's a number of modifiable risk factors. So obviously patients that had previous radiotherapy, that's smoking and alcohol use, it's got at a higher risk, patients with poor oral hygiene, and then any patient that requires dental alveolar surgery. So historically, obviously, it's difficult to state the incidence of osteoradionecrosis due to the fact that in the 70s and 80s, when this trend started and the research on this, they used alpha voltage non-intensity modulated radiotherapy. And the incidence at that time was 30, you know, around the 30% mark. But with the advent of mega voltage radiotherapy in the late 80s and the 90s, it decreased to about 5%. And when intensity modulated radiotherapy became widespread in the early 2000s, we probably have a radiotherapy of osteoradionecrosis incidence of less than 5%. Most recent systematic reviews peg it at around 1 to 2%. Then, anecdotally, we always want to have some cutoff where, you know, when is it safe for me to do dental alveolar surgery or oral surgery in a patient that had osteoradionecrosis. It's basically just so that the dentist or the max fact that removes the tooth can sleep nicely. Some people feel that it's around at 54% or 54 gray or 60%, 60 gray. By Oshio, he's a fellow at the MSK, maxillofacial pathology fellow. Nonetheless, it is actually more complex than that, as the absorbed dose in the bone is often different between different beam designs. And I think that is the thing that needs to be considered more carefully. By and large, the curve for developing osteoradionecrosis is quite flat. I mean, this is obviously not the exact curve. I just used a standard picture, but it's quite flat. If you on the y-axis have the incidence of osteoradionecrosis, and on the and on the x-axis. Thank you. And the x-axis, you've got the radiation dose. There's quite a steep increase from about 60 gray, and that hence that anecdotal cutoff of a patient that received less than 60 gray being safe. However, very few patients receive less than 60 gray in an adjuvant radiotherapy setting. So this is how some of the beam designs look like in the software. So you can kind of target your radiotherapy fairly accurately. However, there's always areas that would be in the direct vicinity of the radiotherapy. And it's important then to discuss with your radiation oncologist if dental alveolar surgery or oral surgery is necessary at a later stage. patient that has got teeth that needs to be removed in this right human mandible, for argument's sake, would be at fairly low risk, whereas posterior extractions in this left human mandible would be of much higher risk. So it's not the fact that the patient had radiotherapy, that the entire mandible might be at similar risk. Then the pathophysiology. So the pathophysiology needs to be elaborated on, as this is kind of guided our treatment philosophies since 83. So initially Marx, the Marx theory basically states that there's abnormal tissue hemostasis due to hypervascular, hypercellular, and hypoxic bone. And then it's largely been superseded by Delaney and Lefort in 2004 that described this fibroatrophic mechanism for the development of osteonecrosis, which more accurately allows us to understand why the process is so progressive, and that it's never really that you are able to kind of reverse the physiology and make the risk of osteoradionecrosis less at a later stage, which Marx initially hypothesized. So I will quickly just talk about the Marx theory. So Marx theory has got this it's got these two arms. Firstly is that the radiation causes direct cell damage and hypervascularity, of hypercellularity, and then these kind of indirect causes, which both includes the loss of cellular function, as well as a hypervascular environment that results in hypoxia. In this hypercellular, hypervascular, and hypoxic environment, it creates this ideal circumstance or a perfect storm for a chronic non-healing wound. And obviously, patients can then develop osteoradionecrosis either spontaneously, as happens in 2/3 of patients, or in about a 1/3 of patients that is preceded by some sort of dental-alveolar trauma, whether that be surgery or from a ill-fitting denture. Then the pathophysiology that's probably more widely accepted at this stage, and that is shaped our philosophy on using the Pentaclo protocol, is that of Delaney. So they describe this radiation-induced fibroatrophic mechanism that is divided in 3 phases. I'll quickly just show you here. So it is they make the argument that so you can have a direct endothelial damage, which results in microthrombi and hypoxia. Then you have injury to the osteogenic progenitor cells, by and large. And then lastly, and most significantly, is what they describe the phenotypic revision from fibroblasts to myofibroblasts. These myofibroblasts, they are quite active cells that secrete a number of pro-inflammatory cytokines, and they result in this dysregulated collagen metabolism. And that very often describes why these areas that we see, if we cut, for argument's sake, if we operate in those areas, that you've got this almost abnormal amount of fibrosis with very little vascularity in that region. These myofibroblasts are programmed to undergo apoptosis, so to stimulate apoptosis of surrounding cells, and that kind of contributes to this hypercellular environment. Then the clinical features. Now, the clinical features I want to just kind of highlight that it's very, very non-specific, and there's a number of differential diagnoses that kind of looks very similar to this, both clinically and radiographically. Chronic suppurative osteomyelitis, florid cemento osseous dysplasia with secondary osteomyelitis, which is very often common in clinical dental practice. Paget's disease that later on developed with secondary osteomyelitis, osteopetrosis, and then obviously what I discussed earlier, medicine-related osteonecrosis, which you see both in patients using anti-angiogenic drugs like the vascular field growth factor receptor inhibitors that's used for some malignancies, and then bisphosphonates more commonly. And lastly, you have to exclude either persistent or a recurrent or a second primary malignancy or a recurrent malignancy. So, I had a few photos of patients, but they were quite poor. I added one or two of our x-rays, but they all were also of poor quality. So as you can see, it's quite non-specific with regards to the symptom complex. The mandible is 24 times more likely to be affected than the maxilla. Not that the fact that the maxilla can't be affected. The maxilla does have a much better blood supply, as it is supplied, both from the enveloping soft tissue as well as central blood supply. So these are three pictures. One is of an Otani grade 1 osteoradionecrosis, where only the dentoalveolar segment is involved above the only the dentoalveolus is involved. This is a type 2 where both the dentoalveolus and the basal bone above the inferior alveolar nerve is involved. And this is an osteoradionecrosis that is a Otani type 3, which implies that it's a full thickness of the bone is involved, or it is associated with oricutaneous fistulas or pathological fractures. And I think we managed a patient like this at Ski just a week ago. They are very, very difficult to manage. So the radiological features, again, like I said earlier, it's quite non-specific. And it's mainly premised around this poorly defined area of sclerotic margin. So in maxillofacial radiology, we always define whether a lesion is well defined or poorly defined, whether there's a sclerotic margin or not, and whether there's a mixed lucent, radiopaque or radiolucent lesion. So by and large, in the early phases, you can have increased radiodensity. And then you tend to develop this mixed lucent opaque lesions with sequestrums. It can present as purely lytic lesions or obviously as pathological fractures. This is a patient from UWC, a photo that someone shared to me. Quality is not great. I had to download it and compress it. But it is clear that you've got a very large area of poorly defined mixed lucent opaque area of a pathological fracture. And it's uncertain whether this was an old extraction site or whether this was developed de novo. I'm not going to really talk about, because I personally, in my opinion, is that there is no role for CT, PET, CTs, MRIs, or SPEC in the management or the diagnosis of this disease. However, literature, and I think some countries have got some money to burn, so they do tend to do it. So there is a lot written about MRIs and identifying early osteomyelitis, osteoradionecrosis, using MRIs, where you've got abnormally low marrow signal on T1 weighted images. So these basically just includes the patients that are at risk of osteoradionecrosis, but we know that because we know they had radiotherapy. So I don't understand why we want to document that as such. And some people, you can do scintigraphic studies as well. So just quickly talking about classifications. So classifications can either be based on the response to hyperbaric oxygen, based on the clinical features, based on the radiological feature, the duration of bone exposure, or the treatment requirements. So the two main classifications that has been used in the last 3 decades has been those based on the treatment requirements by Marks, and then that of used by Otani that uses the radiological features. So these are the two ones I'll just briefly kind of discuss. I think by and large, most maxillofacial surgery units in the world uses the Otani, because Otani is quite simple to use, and it can guide your treatment decision making. I think that is the only thing that you need a classification for. So Marks had this very complex classification where if a patient had osteoradionecrosis, they were given hyperbaric oxygen therapy. at 2.4 atmospheres for 90 minutes, they had 30 cycles. If the patient responded there was complete regression of disease, which he documented in 15% of patients. The patient was retrospectively, so to speak, classified as a stage 1. If a patient was a non-responder initially, they then go on to have some sort of surgery, sequestrectomy, or saucerization of the region, with an additional 10 units of hyperbaric oxygen. If they were responding at the second stage, they were retrospectively stage 2, and all further patients then automatically then become stage 3. And stage 3 is basically where the patient also has an additional a resection. So they would have a resection with a microvascular reconstruction, or a local regional flap, like a PEC flap, with 10 additional dials. So it's quite a complex staging system, which if you in your unit you don't use hyperbaric oxygen, you can obviously not utilize this. And I'll discuss the hyperbaric oxygen controversy in just a minute. Then Notani is very simple. So stage 1 is where only the dental bone is involved. Stage 2 is all of the bone above the inferior violar nerve is involved, implying it involves the basal bone above the inferior violar nerve as well. And stage 3 is where it extends below the inferior violar nerve, is pathological fractures or orocutaneous fistulas. Yeah, so this very clearly dictates the treatment algorithm, which I'll quickly kind of elaborate on a bit later. Then with regards to the management, so I'm going to use this kind of table to discuss the management. So patients that are at risk of osteoradionecrosis, those are patients that had that you can obviously things that you can do pre-radiotherapy, things that can be done, post-radiotherapy to prevent patients from getting osteoradionecrosis, and then the controversies with regards to the management of established osteoradionecrosis. There's a number of non-surgical management philosophies, then as well as surgical. So let's start with the oral screening. This is a screenshot of the University of Pretoria dental extraction kind of decision-making tool that the dentists have to decide whether they need to extract or not extract in patients being sent from radiotherapy. And don't need to read it here. I've got it a little summary here. So it basically works about the dental IQ of a patient. That implies dental IQ. Just about the patient's how often they visit the dentist, oral hygiene measures, etc. Historical dental care, which is quite important. Patients that has got heavily restored mouths with multiple kind of root canals, crown and bridge work, etc., are obviously at higher risk of developing latent dental sepsis than the patient with a virgin kind of dentition. Then the ability to follow up, which in South Africa becomes a significant, definitely one of the socioeconomic things you have to consider. Dexterity to maintain proper oral hygiene, even though a patient might have a high dental IQ, a patient that had a CVI or has got Parkinson's disease or has got severe osteoarthritis don't necessarily have the ability to maintain proper oral hygiene. Then existing dental pathology, patients with caries in the mouth, periodontal disease, they've got some root rest in the mouth. Those patients are obviously those factors need to be considered, and then additional risk factors for osteoradionecrosis. If patients are additionally taking industrial doses of steroids for ulcerative colitis or whatever the case might be, or they are smokers, heavy alcohol users, they are at a significant risk of developing osteoradionecrosis, and you should probably be more aggressive in deciding which teeth you're going to remove. So there's high risk, low risk. It's somewhere I missed this, but the high risk patient would be patients with multiple restorations that's got missing teeth, socioeconomical factors. So patients that doesn't have kind of money to transport, or they far removed from a dental clinic, etc. And then if you compare that to a patient with that's got a healthy dentition and they've got a means to kind of maintain proper oral hygiene. So it's a multifactorial kind of decision making, and it's not so simple. If it is that the decision gets made for teeth to get extracted, it should be done at least 21 days before radiotherapy, and that is according to the parameters of care document by the American Association of Maxillofacial and Oral Surgery. Just to at least allow soft tissue healing prior to the start of radiotherapy. Then I'll quickly just talk about oral maintenance. Again, there's no universal guidelines, but the ADA recommends that patients have 6 monthly or biannual dental visits. In-office fluoride treatment. So there's 2 types of fluoride treatment that can be given in office. It's 2% sodium fluoride and 1.23% APF, which is acidic phosphofluoride. And then the aim of those dental visits is to do preventive treatment, scaling and polishing, do endodontic procedures, do small fillings in areas where there might be some early dental decay, etc. Obviously, reinforce good oral hygiene instructions to patients, and then a number of home-based things. So patients needs to brush a fluoridated toothpaste. They recommend 1.4 million parts per unit fluoridated toothpaste. So that's what most of toothpastes are, of adult toothpaste on this African market has. Then patients should floss daily, rinse with non-alcohol mouth rinses. They should have frequent water sips. Or they can use sugarless or non-caffeinated drinks. That's basically just to stimulate the salivary flow and rinse out any food debris, etc. Restrict your sugar intake and obviously stop smoking, alcohol consumption. Then this is now we're going to come to some of the literature and the controversies. So there's a lot of controversy with regards to strategies to prevent patients at risk of osteoradionecrosis, of developing osteoradionecrosis. So there might be a subgroup of patients that even though they went through a dental screening 5, 6, 7, 8, 9, 10 years later, they might need a tooth extraction, or they might have a dental abscess that needs treatment and needs some dental alveolar surgery. And in that setting, there's a number of modalities, and the 2 most prominent modalities is hyperbaric oxygen and then the pentaclo regimen that could potentially be used to decrease the risk of developing osteoradionecrosis. The data on this is quite scanty and quite poor. The initial hyperbaric oxygen therapy protocol that was devised by Mark in 1983 was the 2010 protocol, where patients received 20 preoperative dives of hyperbaric oxygen. They then undergo the dental extraction or the implant or whatever the case might be, and then they have a post-operative. They have additional 10 dives. And Mark's in 1990, the 1983 study is the one I discussed earlier, is where he basically had a stepwise. It wasn't a controlled study. He just had a single sample of 153 patients. He treated all of them, found 15% responded with only hyperbaric oxygen, 15% responded with minor debridement to hyperbaric oxygen, and 65% of the patients responded with a resection hyperbaric. But in 1994, he had 74 patients that required entectomies. These are patients that previously had radiotherapy. The mean dose of radiotherapy at that time was 74 gray, and he found that 5.4% of patients developed in the hyperbarics group, whereas nearly 1/3 of patients developed osteoradionecrosis in a non-hyperbaric group. So hence the hyperbaric oxygen therapy has been the standard of care both in the US as well as, I would probably say, the majority of the world up until the early 2000s. So the big controversy here is these are probably the 3 most prominent studies. So the first one is a Cochrane review, which studies 17 randomized controlled trials that included 752 patients, showing only moderate evidence for increased mucosal coverage and improved post-extraction healing. The issue with this is all these randomized controlled trials have got significant risk of bias, and they've got small sample sizes. Within 17 studies, you only have 750 patients. Then the most recent and one of the studies that in University of Victoria made us decide to do away with the hyperbaric oxygen pre-extraction was the HOP-ON phase 3 randomized controlled trial. It was run in the UK by 10 units in Leeds, Merseyside, and down in London. So this is level 1 evidence. It initially recruited 137 patients, but only 100 patients were finished the study, so they had quite a high attrition rate. But it showed no difference between the patients that had hyperbaric oxygen prior to extraction and those patients that only had extraction with a kind of minimally traumatic surgical technique, or just good surgical technique. And then the last trial is the Danish trial. It is currently still running. I got a preliminary result, but it's all written in Danish, so I couldn't. I obviously didn't include it. We'll wait until the final results become available, and then they'll obviously publish it in English as well. And then another strategy, a preemptive kind of preventative strategy, is the use of pentaclone. So this is based on this radiation-induced fibroatrophic theory from Delanian, where they use pentoxifylline, tocopherol, and chloride. So pentoxifylline is a very strong angiogenic drug. It's got a anti-fibroblast activity, so it kind of mitigates that aberrant myofibroblast activity. And lastly, it's also anti-tumor necrosis factor alpha drug. Tocopherol is again a potent. Tocopherol is actually just vitamin E, standard vitamin E. You can buy it over the counter. It is a strong antioxidant and it stabilizes cell membranes. And clotronate is a first generation. It's a very old bisphosphonate, which are used at these doses. Are able to obviously inhibit osteoclastic function, but also upregulate osteoblastic function, as well as it's a very strong anti-inflammatory effects. It prevents, or it inhibits interleukin 1, 6, and tumor necrosis factor alpha. So based on this fibroatrophic kind of dysregulated response, they've devised this treatment protocol. I wanted to say, so the only study that's ever been done was a study by Patel in 2016, where they prophylactically used pentoxifylline and tocopherol for 4 weeks pre-extraction and then 12 weeks post-dental extraction. At the end of the day, it was prescribed for 12 weeks, but the mean time period that patients used it post-extraction was 11 weeks. And even though they didn't have a control arm in the study, they found that 1.2% of patients developed osteoradionecrosis and 390 extractions. I think that 390 extractions in 84 patients. So yet the sample size is not very big. And if you look at the systematic reviews that was published more recently in 2018 and 19, the rate of osteoradionecrosis is around about that 1 to 2%. So whether the prophylactic use of the pentoxifylline and tocopherol actually reduced the rate of osteoradionecrosis is unknown. So now that we've kind of looked at the preventative strategies, what shall we do with patients who have established osteoradionecrosis? And I think people that manage osteoradionecrosis on a frequent basis know how difficult it is to treat. And just how stubborn the disease is. So there's a number of strategies. So non-surgical adjunctive therapies is long-term chlorhexidine rinses, antibiotics, steroids, and obviously analgesia. Hyperbaric oxygen comes into the picture again, and then the pentaclone regimen. And lastly, and most recently, they started using recombinant human parathyroid or teriparatide, which I don't think is something in this African setting, as it's quite expensive, as I understand. So this is some of the more prominent studies around hyperbaric oxygen therapy established at ORN. As I said initially, Marx had this, he pegged it at a 95% recovery using his hyperbaric oxygen. The issue that I've got to the study is he didn't define what is a complete recovery, and he only had a follow-up period of 84 or 87 months. A lot of these patients we know have bone exposure again 8, 9, 10, 11, 12 years after radiotherapy, because this disease isn't as static as he initially thought. It's more progressive. Secondly, he did a study in 1994 where he looked at the cross section of patients, of tissue biopsy samples of patients that had radiotherapy, or that had hyperbaric oxygen or not, and he found a 75 to 85% increase in microvascular density. But that was counteracted by a study a few months later that showed that patients if you use a pulse oximetry on irradiated tissue, the pulse oximeter oxygenation levels are similar in irradiated and non-irradiated. So it kind of mitigated his theory at that time. Then Feldmeyer and Freiberg, these are both Germans at Heidelberg University, and I can't remember the other one, had retrospective studies of 370 and 65 patients respectively. They showed cure rates of 83 and 87% at 12 and 82 months respectively. They used both hyperbaric oxygen therapy as well as surgical intervention. So they would have done a sequestrectomy or source realization, and a subset of their patients also had free flap microvascular reconstruction. The attrition rate of Freiberger's study was quite high. 13 patients dropped out in that period. And then the only randomized controlled trial that was ever done for hyperbaric oxygen and established ORN was the ORN96 trial that was run in Paris. It included 12 units across France. They had this fail-stop mechanism to make sure that the trial doesn't continue if there's no benefit. At the end of the day, the aim was to recruit 222 patients. However, with the initial result coming out, they did a y-axis assessment or whatever, I don't know what it's called, and they had to stop the study early, with only 68 patients recruited, as they found that patients that received hyperbaric oxygen therapy actually did worse than the patients that did not receive hyperbaric oxygen therapy. Another problem with the study is they only used Titania 1 and 2, so patients with pathological fractures or cutaneous fistulas were excluded from the study. And secondly, they didn't include, within the protocol design, there was no stipulated period at which surgery are part of the treatment algorithm. To be frankly honest, they used the need for surgery as a failure of treatment, which we all know should probably not be done, because hyperbaric oxygen therapy should be an adjunct to surgery. So Martin, like I just said there, that's basically all I said just now. Yeah, so the pentaclo, I'll just quickly talk about some of the pentaclo. I've quickly elucidated already how the pentaclo regimen is prescribed, but this is some of the prominent studies. This is a study that made most people sit up. There's Delaney 2011 study. Delaney in 2005, just after describing his radiation-induced fibroatrophic theory, had a prospective study of 18 patients. It wasn't randomized, there was no control group. It found that 89% had complete resolution of ORN that was resistant to hyperbaric oxygen therapy. So the inclusion for his group there was all patients had to have hyperbaric oxygen therapy. If they did not have complete mucosal coverage, they were then given a period of 18 months of pentaclo, and they found that 89% had mucosal coverage after that. If you look at the pictures in the study, it is quite miraculous, and I think that has started this pentaclo craze. Then he followed this up with a prospective study of 54 patients. Again, these patients were not, there was no control group. That found 100% recovery within a mean of 9 months. This was a phase 2 trial. They prescribed the Pentaclo for a minimum of 18 months and a maximum of 24 months. And I mean, obviously with 100% recovery rate, I think most people at that time decided to kind of use the Pentaclo as a standard of care. This was followed by Alliance, which is a US author. These are obviously the lady is French. That also did a prospective study. Again, there was no control group. It only included lesions with a bone exposure of less than 2.5 centimeters, cubic centimeters. And they also had 100% complete resolution, or at least bone coverage. And then more recently, in 2020, it was published in the Laryngoscope, was a study by Desard, also a prospective study, including 27 patients, but the dropout rate was 12, so only 15 patients completed the study, and they reported a 78% complete recovery. So at this stage, the best data to support the Pentaclo is that of level 4 evidence at most. So in that setting, the National Institute of Clinical Care and Excellence in 2012 then recommended that Pentaclo should only be used in clinical trials. And that is one of the arguments I've been making. If it is that we are prescribing Pentaclo to patients, I don't think we should be prescribing it willy-nilly. We should be doing it within an environment where the data is properly kind of captured and analyzed to see if this is actually the way forward. And currently in 2021, this is a pilot study that aims to compare the hyperbaric oxygen therapy with the Pentaclo. Obviously, it hasn't been launched yet, and they will start enrolling patients for this pilot study, or for the full study in 2022. And then the last medical treatment that is available is that of human recombinant parathyroid hormone. It has never been tested against any other treatment modality. The pathophysiology, the physiological basis is just based on the fact that low doses of intermittent exposure has an anabolic effect on bone metabolism. The FDA has approved it for osteoporosis, but it's used off-label for both medicine-related osteonecrosis as well as osteoradionecrosis. And then lastly, as an established ORN, is surgical interventions. So this is the Notanic classification. If you use a Notanic classification, stage 1 and stage 2 patients should receive sequestrectomy with minimal soft tissue manipulation. You can use mucoperiosteo flaps to try and advance to close the bone. It's my experience, which is obviously level 9 evidence, that these wounds just go open. So try and minimally manage the soft tissue nonetheless. And then stage 3 disease, which obviously extends below the infraalveolar nerve, requires segmental resections. It has to be cut back to bleeding bone with microvascular reconstruction. I think the big thing about the microvascular reconstruction that people also take into consideration is the fact that you bring in vascularized tissue, but it has to heal in a non-vascularized bed. So even the soft tissue needs to be cut back to a place where there's adequate bleeding, which can sometimes result in very large defects. Often you have the essence between the free vascular flap and the tissue bed. And then there's been 1 or 2 studies comparing the use of PRFs. PRFs is something that Max Fax use very commonly in dental implant surgery or dental alveolar surgery. It's basically you take a blood sample, you spin it off, you find some of this platelet rich fibrin, which contains all the growth factors, and you can then layer that on top of wounds, and it theoretically improves the wound healing. So one prospective controlled study showed 77% resolution with PRFs and 60% without. So by and large, we should be using combination therapies, combined treatment using hyperbaric oxygen, or pentaclo with or without surgery and PRF seems to yield superior results when you use only individual therapies in isolation. And I think that's probably the thing that we should be doing is combining hyperbaric oxygen with surgery or pentaclo with surgery. So there's a number of questions we have to ask ourselves, and these are the questions we still don't have answers to. Is it ever safe to do an extraction after radiotherapy? And I think the answer to that is we don't know. We know that about 1 to 2% of patients after an extraction will develop osteoradionecrosis. Is there something that we can do pre-extraction? Does hyperbaric oxygen, pre-treatment hyperbaric oxygen therapy work? And the answer to that is we still don't know. Should we use the pre-extraction pentaclo? The answer to that is we don't know. In established ORN, should we use perioperative hyperbaric oxygen with surgery to treat patients with, or should we treat patients medically with pentaclo and or surgery? And again, the answer to that is we don't know. So there's a lot of unanswered questions within this topic, and yeah, I think we need to be able. The big issue with designing trials in osteoradionecrosis, firstly, it's a low number of patients, and secondly, there's this historic idea that the standard of care was hyperbaric oxygen therapy, and not giving that to patients would is tantamount to unethical kind of treatment. And I think once those paradigms are challenged, I think we can design proper clinical trials and answer these questions. So as a conclusion, ORN, as we all know, is a catastrophic complication of radiotherapy. The prevention through pre-treatment screening and continuous preventative treatment is probably the best here. So prior to starting radiotherapy, that initial consultation with either the dentist or, preferably by a dentist that has some experience in treating patients with hyperbaric oxygen therapy, and a continuous program of preventative care is probably the best way of treating this. At this stage, there is insufficient data to support evidence-based practice in terms of both hyperbaric oxygen therapy and pentaclo. And if your unit uses one of these treatment modalities, I think we should really look at ourselves and document it and report our experiences, just so that others can also learn from it. And then we have to be on the lookout for some of the trials that's currently running that both assesses the efficacy of hyperbaric oxygen and pentaclo in the prevention and the treatment of ORN. Yeah, so I don't know if there are any questions.
Thanks very much, Stefan. That was really great, very in-depth, but also dumbed it down for those of us that need some advice when it comes to these difficult patients. I don't know if there's any questions from the floor for Irfan, or any comments, anyone on the call from Max Fax or Oncology or any of the other teams. I don't see any messages in the chat function. I don't see any hands raised. You've clearly wowed everyone with your presentation, Emma. Okay, if there's no other further questions, then I think we'll proceed to end the meeting. Thank you so much to everyone that joined this morning. We've had quite a nice turnout, so that's a compliment to Irfan. And as always, it's always a pleasure to have different people from different teams presenting this platform. So thanks very much. If there's no further questions, I'm going to end the meeting. Have a good week, and then we'll see you again on Friday morning for another presentation.